Okay, let's unpack this. Have you ever stopped to think about how that little jab in the dentist's chair completely takes away the pain, yet you're wide awake and aware?
Uh-huh.
Or how a simple injection can allow for a minor surgery without you feeling a thing? It's truly fascinating, isn't it?
It really is.
We often take these moments of pain relief for granted, but behind that seeming simplicity lies, well, an unsung hero of modern medicine, local anesthetics.
Definitely. And they're not just pain-numbing drugs. They are incredibly sophisticated agents performing this intricate chemical dance.
Right, allowing us to undergo procedures without discomfort.
What's fascinating here is that while local anesthetics are incredibly common, their underlying science is profound, really deep.
Yeah.
Today, we're going beyond the surface to truly understand these remarkable drugs. We'll explore how they reversibly block electrical impulses, influenced by everything from the, microscopic nerve level to their unique chemical makeup. We'll even touch upon their surprising new roles in pain management and, critically, the crucial safety considerations.
Absolutely. And this deep dive isn't just for medical professionals, right?
Not at all. It's for anyone who wants to feel truly well-informed, maybe even master this information like an elite professional about, well, a cornerstone of modern medicine.
Exactly. Our mission today is to give you that shortcut to mastering this complex topic. We'll explore the intricate anatomy of nerves, that electrical symphony that allows them to function,
The basics.
and then precisely how local anesthetics interrupt this symphony. We'll dive into the specific factors that make each local anesthetic unique in its action, its chemistry, how the body handles it.
All those details.
And critically, we'll cover how to ensure their safe and effective use, including understanding and managing potential risks. Get ready for some serious aha moments,
Fully.
because you're about to gain a truly comprehensive understanding of these amazing drugs. So before we can truly understand how local anesthetics work, we need to grasp what they work on.
Makes sense.
Think of it like this. You can't properly understand how to stop a signal without knowing how that signal is sent in the first place. The peripheral nerve is, well, it's a complex functional unit.
Yeah, the body's electrical wiring system, basically.
Exactly.
Okay, let's start with the basic building block, the axon. This is the long, slender extension of a nerve cell, like a tiny electrical cable that transmits signals.
Okay.
Every axon has an outer skin called the cell membrane, or axonema, and its internal fluid, the axoplasm.
Axonema and axoplasm. Got it.
Surrounding these axons are specialized support cells called Schwann cells. They're vital for the nerve's health and function. Really important.
Von cells. Okay.
Now, how these Schwann cells are arranged is key to nerve function. In what we call unmyelinated nerves, a single Schwann cell loosely covers several axons. Think of it like several bare wires bundled together, kind of loosely.
Right. Okay. Less insulated.
Exactly. But in larger myelinated nerves, the Schwann cells form a much more elaborate insulated structure. They wrap themselves around a single axon in multiple concentric layers, creating a fatty insulation called myelin. Think of this myelin like the thick plastic insulation around a high-speed electrical cable.
So that's the difference. Myelinated means heavily insulated.
Precisely. But this insulation isn't continuous along the entire length of the nerve. There are periodic, tiny gaps in the myelin sheath.
Gaps.
Yeah, almost like exposed sections of the wire, and these vital gaps are called the nodes of Ranvier.
That was the Ranvier. Okay, why are they so important?
This is where it gets critically important for our discussion. The specialized voltage-gated sodium channels, or sodium gates as we can call them, those are primarily concentrated in these non-myelinated nodes.
Ah, so that's the target.
That's the main target where local anesthetics exert their blocking action, right there in the nodes.
Okay.
Because of these nodes, the electrical signals or action potentials, they don't just smoothly slide down the axon.
Right.
Instead, they jump or leapfrog from one node of Ranvier to the next. This incredibly efficient process is called saltatory conduction.
Saltatory conduction.
Yeah.
The jumping.
Exactly. And it significantly speeds up how quickly nerve impulses travel along myelinated nerves. Makes them much faster.
Makes sense.
Now, here's a point that might seem a bit counterintuitive.
Uh-oh.
Myelinated nerves are larger and transmit impulses much faster, right?
Yeah.
But they can actually be more difficult to anesthetize with local anesthetics than unmyelinated nerves.
Really? Why's that?
Well, partly because that thick myelin insulation acts as a barrier. The drug needs to penetrate that fatty layer before it can reach its target sodium gates in the nodes. It takes longer.
Ah, okay. The insulation slows down the drug getting in.
Exactly. And beyond the individual axons, peripheral nerves are highly organized. They're bundled together and protected by three crucial layers of connective tissue. Think nested layers of protective casing around a complex cable.
Okay, 3 layers.
The innermost layer, the endoneurium, is delicate tissue surrounding each individual axon within its bundle.
Endoneurium. Inner.
Then, the perineurium is a stronger layer that binds groups of these smaller bundles together, like a thicker casing.
Perineurium. Middle bundle.
And finally, the epineurium is the outermost, toughest layer encompassing all the smaller bundles to form the entire peripheral nerve, like the main jacket around a big electrical trunk cable.
Epineurium. Outer jacket. Got it.
And these connective tissue layers are profoundly important because they serve as crucial barriers. Local anesthetics must diffuse through them before they can reach those target sodium gates within the axons.
The drug has to get through all those layers first.
Right. The thickness and composition of these layers directly impact how quickly and effectively a local anesthetic can spread and work. Big factor.
Wow, okay, so that's the structure. What about the actual electrical signaling?
Right, let's talk about the nerve's fundamental language, electrophysiology, how it sends electrical signals.
Okay.
When a peripheral nerve is at rest, not actively transmitting a signal, there's a negative voltage difference across its membrane, like a tiny charged battery.
A negative charge.
Yeah, typically around -70 to -90 millivolts. This is the resting membrane potential. It's the nerve's ready state, poised to fire.
Okay, ready state. How does it get that negative charge?
It's created by an ionic imbalance, an uneven distribution of charged particles, primarily sodium and potassium ions, between the inside and outside of the axon.
Sodium and potassium.
The key player here is an active, energy-dependent pump on the nerve membrane, the sodium-potassium pump. It's constantly working.
A pump? What does it do?
It diligently moves sodium ions out of the cell and brings potassium ions in. This establishes the crucial chemical gradient, this difference in concentration.
So it pumps sodium out, potassium in, actively.
Actively, it takes energy. Now, the nerve membrane is somewhat porous or permeable to potassium, so some potassium leaks out down its concentration gradient.
Okay.
This outflow of positive potassium ions leaves behind negatively charged particles inside the cell, creating that negative charge.
Ah, so the positive leaving makes the inside negative.
Exactly. And that negative charge then acts like a magnetic force, pulling some potassium back in. So there's this delicate balance.
Push and pull.
Right. A constant tug of war between concentration pushing potassium out and electrical attraction pulling it back in. The net effect is a slight outflow of potassium, keeping the inside of the nerve negative at rest.
Fascinating balance. So that's the resting state. What happens when it fires?
Okay, the real action begins when a nerve fires and an action potential is generated. When an electrical impulse stimulates a resting nerve and reaches a certain threshold.
The trigger point.
Right. Those voltage-gated sodium channels in the membrane suddenly burst open.
Gates fly open?
They do, and this allows a rapid, uncontrolled influx of sodium ions from outside the cell, where there's tons of sodium, to rush into the nerve.
Sodium rushes in.
This sudden flood of positive sodium ions completely reverses the membrane potential, briefly making the inside of the nerve positive, maybe up to plus 20 millivolts. That rapid change is the electrical signal.
The action potential itself. Wow. How does it reset?
Good question. Then comes the repolarization process. The nerve rapidly resets itself. Once the membrane reaches its peak positive charge, those sodium channels quickly snap shut, stop the influx.
Sodium gates close.
Almost immediately, potassium channels open, allowing potassium ions to rapidly diffuse out of the nerve, following their gradient now.
Potassium rushes out.
This outward movement of positive potassium ions quickly restores the negative resting membrane potential. Then the sodium-potassium pump kicks back into high gear, actively removing the excess sodium that rushed in and bringing potassium back.
Tidying up, basically.
Fully resetting the neuron, getting it ready to fire again. And while many ion channels are important, these voltage-gated sodium channels are the most significant for initiating and propagating that rapid action potential. They're the stars of the show.
So what does this all mean for us? It means the nerve is constantly poised, like a tightly wound spring ready to fire. And that firing is all about tiny gates, these sodium channels, opening and closing in a precise, rapid sequence. Here's where it gets really interesting. Understanding how local anesthetics precisely interrupt this delicate electrical symphony.
Exactly. Now that we have that foundational understanding of how a nerve sends its electrical messages, Let's delve into how local anesthetics precisely disrupt this signaling.
Okay, the mechanism.
The core mechanism is quite elegant and, importantly, reversible. Local anesthetics work by binding to and blocking those very important voltage-gated sodium channels, those sodium gates we just discussed.
They physically block the gates.
They bind to them, effectively blocking them. Now, to understand this binding, we need to know that sodium channels aren't just in one state. They actually have three functional forms.
3 states?
Yep. A closed resting state when the nerve is quiet, an open active state when the nerve is stimulated and sending a signal,
Right.
and an inactive state, which is a temporary refractory period right after it fires when it can't respond again for a brief moment. These states describe the dynamic changes the channels go through during depolarization and repolarization.
Resting, open, inactive.
Here's the crucial point about how local anesthetics work. They preferentially bind to receptors when the sodium channels are in their open or inactive states, not when they are simply closed and resting.
So they like them better when they're active or just finished being active?
Exactly. This means the local anesthetic is most effective when the nerve is actively firing or has just fired. This binding essentially locks the channel in a non-functional state, preventing sodium from rushing in.
Okay, so it locks the gate shut, but mostly when it's already been used.
In a way, yes. This also explains why local anesthetics demonstrate what's called use-dependent block.
Use-dependent. What does that mean?
Essentially, they work faster and more effectively when the sodium channels are repeatedly opening and closing. The more frequently a channel is stimulated, which is precisely what happens with high-frequency pain signals, the more time it spends in those open and inactive states, making it more available for the local anesthetic to bind and block it.
So that's why they target pain signals so well.
Nah.
Because they fire rapidly.
That's a key part of it. It's a very clever, targeted action. They hit the busy channels harder.
Brilliant. So how does the drug actually get to the receptor to do this?
Good question. Local anesthetics inhibit nerve signals by binding to specific receptors located within or adjacent to the internal opening of the sodium channel.
Internal opening, so inside the nerve cell.
Precisely. Studies have clearly shown that these receptors are on the intracellular side of the nerve cell membrane, inside the axon.
Okay, that's critical. So the drug has to get inside the nerve cell first.
For most clinically useful local anesthetics, yes, they need to get inside the axoplasm to reach their target.
Okay. How do they do that? Isn't the membrane a barrier?
It is. Most local anesthetics, with the notable exception of benzocaine, are what we call tertiary amines. When injected into the body, they exist in two forms.
Two forms.
Yeah, a non-ionized lipid-soluble form, which is fat-loving, and an ionized water-soluble form, which is water-loving.
Fat-loving and water-loving. Okay.
The proportion of each form depends on the drug's pK, that's a measure of its acidity or basicity, and the pH of the surrounding tissue.
Right, the local environment matters.
Absolutely. Here's the sequence of events. First, the lipid-soluble, non-ionized fraction, the fat-loving part, is the one that can easily diffuse across the fatty nerve cell membrane to get inside the neuron's interior, the axoplasm.
So the fat-loving form sneaks through the fatty membrane.
Exactly. Once inside the neuron, a new balance is established between the ionized and non-ionized forms. And here's the key. It is primarily the ionized water-soluble fraction that actually binds to the receptor on the inside of the sodium channel, thereby blocking it.
Wow. So it needs the fat-loving form to get in, but then it needs the water-loving form to work once it's inside.
You got it. It's a two-step process for most of them. Needs to be lipid-soluble to cross, then ionized to bind.
Fascinating. You mentioned benzocaine is different.
Yes, benzocaine is a fascinating exception. It's unique because it's permanently non-ionized, or neutral. It doesn't switch forms like the others.
Always fat-loving.
Essentially, yes. This special chemical structure allows it to directly penetrate the lipid nerve cell membrane and inhibit the sodium channel without needing to first enter the axoplasm.
So it works from outside or maybe within the membrane itself?
It's thought to act directly within the lipid bilayer, or very close to the channel from there. It doesn't need to convert forms inside the cell, which explains its unique properties, especially for topical use.
Makes sense why it's used on the surface a lot then.
Right. Now, while their primary action is on those sodium channels, local anesthetics also have additional cellular effects.
Oh, like what?
They can influence other signaling pathways within cells, affecting things like intracellular calcium signaling. It's not just one target.
Okay, broader effects.
And this broader influence may contribute to their anti-inflammatory action that's sometimes observed.
Anti-inflammatory, how does that work?
Well, for instance, they can prevent an overactive inflammatory response by suppressing certain immune cell activities, kind of calming things down, without necessarily compromising the body's essential defenses. It's quite a nuanced effect.
Interesting. So not just numbing, but maybe reducing swelling too.
Potentially, yes. It's an area of ongoing research, and it's important to acknowledge that despite all this research, many questions remain.
Like what?
Like the precise ways local anesthetics produce all their clinical effects in different types of nerve blocks. It's possible that slightly varied mechanisms or interactions with different receptors are involved when they act on peripheral nerves compared to, say, spinal or epidural effects.
So location matters too.
It likely does. The body's complexity means there's always more to learn and discover. We don't have all the answers yet.
Fair enough.
So if we connect this to the bigger picture, it's definitely not just about turning off a switch. It's about a dynamic, intelligent interaction, where the drug needs to be in the right form, at the right place, at the right time to exert its precise effect. This precision is what makes them such powerful and versatile tools in medicine.
Now that we understand the basic mechanism, how they intercept that nerve signal, let's explore why some local anesthetics are chosen over others, and what fascinating factors influence their behavior in the body.
Yeah, this is where it gets really practical.
This is truly where the art of anesthesia meets the science, isn't it? Clinicians tailoring their choices for the best outcome.
Absolutely. And one of the most intriguing aspects is nerve fiber sensitivity and differential block.
Differential block, what's that?
It refers to the observation that different types of nerve fibers have varying sensitivities to local anesthetics, meaning different nerve functions are lost in a specific, predictable sequence.
Oh, so it doesn't just shut everything off at once.
Not usually, no. Typically, in most major nerve blocks, autonomic function, things like blood vessel control, is lost first. Then the perception of superficial pain, followed by touch, then temperature, and finally motor function, movement, and proprioception, our sense of body position.
Wow, that's a specific order. Pain goes before movement.
Often, yes. This phenomenon is called differential blockade.
Can you give an example?
A powerful clinical example is the use of bupivacaine epidural for labor pain. It's remarkable because it provides excellent pain relief analgesia while sparing motor function.
Right, so the mother can still push.
Exactly. Which is crucial for laboring mothers. It's like having a dimmer switch effect rather than just an off switch. Incredibly valuable.
Definitely. How does the body know which function to block first? Is it the nerve type?
It has a lot to do with the nerve fiber types. We broadly classify nerve fibers into groups A, B, and C based on their size and whether they have that myelin insulation we talked about.
Size and insulation matter.
They profoundly influence conduction speed and thus their sensitivity to local anesthetics. Think of it like a mix of heavily insulated fast wires, like A fibers for motor control, lightly insulated wires, B fibers for autonomic function, and uninsulated slow wires, C fibers, often for pain.
So the general idea is bigger, faster, more insulated nerves are harder to block.
That's the general principle, yes. Smaller, slower, or less insulated nerves, like many pain fibers, C fibers and small A delta fibers, and autonomic B fibers, are often easier to block and get blocked earlier.
Okay, but you mentioned counterintuitive points earlier.
Right. There are nuances. While it seems logical that the smallest, unmyelinated C fibers would be easiest to block, some studies have shown them to be surprisingly more resistant in certain contexts than slightly larger A delta or B fibers.
More resistant? Why?
It might relate to something called the conduction safety concept. Essentially, smaller, slower nerves sometimes have a greater safety margin in their electrical signal transmission. It takes more to completely shut them down.
Huh. A bigger safety buffer.
Something like that. Another factor is simply how easily the local anesthetic can diffuse through the protective layers, especially the myelin sheath. The thick myelin around larger fibers creates a significant barrier, slowing down drug penetration.
So diffusion speed is key too.
Absolutely. Ultimately, recent theories suggest differential blockade is a complex interplay of many factors. Nerve fiber length exposed to the drug matters, especially in the epidural space. How frequently a nerve fires is important. Motor nerves fire slower than pain nerves, often needing higher drug concentrations to block. Different types of sodium channels might be involved.
Wow.
And of course, the specific local anesthetic used makes a difference too. It's far more nuanced than just size or insulation alone.
Okay, that's complex. Let's move to the drugs themselves, the chemical structure and classification.
Right, this is fundamental. All clinically used local anesthetics have three characteristic parts.
3 parts.
Yep. First, a fat-loving aromatic ring system. This helps the drug penetrate those fatty nerve membranes.
Okay, fat-loving part.
Second, an intermediate chemical link. This can be either an ester or an amide bond, and this link is the critical differentiator. It determines the drug's classification.
Ester or amide, that's the key difference.
That's the major chemical difference, yes. And third, a water-loving amide bind. This part allows the drug to dissolve in body fluids and eventually bind to its target receptor, usually after becoming ionized.
Fat-loving ring, ester-amide link, water-loving end. Got it. Why is the link so important?
Because the crucial distinction between ester and amide linkage has profound clinical implications. It determines how the drug is metabolized, how long it lasts, and its potential to cause allergic reactions. Big differences.
Okay, how can we tell them apart?
There's a simple memory aid. Esters have one I in their generic name. Think procaine, tetracaine, chloroprocaine.
1 I for esters, okay.
While amides have two IS. Think lidocaine, bupivacaine, ropivacaine, prilocaine.
2 IS for amides. Lidocaine, bupivacaine. Okay, that helps.
It does. And even minor chemical tweaks within these two groups, adding a small chemical group here or there, can significantly change a drug's potency, its speed of onset, its duration, and its ability to produce that differential block we talked about.
Tiny changes, big effects.
Exactly. Underscores the incredible precision of pharmaceutical chemistry.
Okay, so structure matters hugely. Now, how the body handles them and their effects, pharmacokinetics and pharmacodynamics.
Right. Pharmacokinetics is what the body does to the drug. Absorption, distribution, metabolism, excretion. Pharmacodynamics is what the drug does to the body, its effects.
Got it.
Now, here's a key conceptual difference for local anesthetics compared to most drugs. Most drugs need to be absorbed systemically to work throughout the body.
Yeah.
But local anesthetics are intended to remain localized at the site of injection or application. In fact, systemic absorption getting into the bloodstream actually terminates their effect at the target nerve because it moves the drug away from the site of action.
Oh, right. You want it to stay put. Absorption is bad in this case.
Generally, yes, for the local effect. The longer the drug stays concentrated at the nerve, the more intense and prolonged the block will be.
Okay. Let's talk potency. How strong are these drugs?
There's a strong correlation between a local anesthetic's lipid solubility, its fat-loving nature, and its potency.
More fat-loving means more potent.
Generally, yes. Think about it. The nerve membranes are mostly lipids, fats. So more lipid-soluble drugs can pass through these nerve membranes more readily and bind more strongly to those sodium channels inside.
Makes sense. What does that mean clinically?
More potent, fat-loving local anesthetics tend to bind with higher affinity to the sodium channels. The consequence is clear. Increased fat solubility generally correlates with increased potency, a longer duration of action because they stick around longer.
Okay.
And unfortunately, also a higher tendency for severe cardiac toxicity if they happen to get into the bloodstream in high concentration.
Potency comes with a risk.
It can, yes. This means fewer molecules or lower concentrations of these potent drugs are needed to achieve the desired blockade. For example, adding a butyl group to mepivacaine creates bupivacaine, which is about 26 times more lipid-soluble and 4 times more potent. Small change, big difference in potency.
Wow, so duration of action is also linked to this, how long it lasts?
Directly related, yes, to both how strongly the drug binds to proteins in the body and its lipid solubility.
Protein binding matters too.
Yes, drugs that bind more firmly to proteins and lipids in and around the nerve will stay in place longer, producing a prolonged block. The sodium channel receptor itself is a protein.
Okay.
So high protein binding agents like bupivacaine, which is over 90% bound, last significantly longer than less protein bound drugs like mepivacaine, which is about 65% bound.
High binding equals long duration.
Generally. Also, how the drug affects blood vessels at the injection site plays a big role in duration because that affects how quickly it's washed away. We'll get to that.
Okay. What about onset of action? How fast does the numbing start?
Onset depends on several factors, but probably the most important is the state of ionization.
Back to the fat-loving versus water-loving forms.
Exactly. Remember, the fat-loving non-ionized form crosses membranes easily, but the water-loving ionized form binds to the receptor. Local anesthetics are weak bases, and their pKa tells us the pH at which half the drug is ionized and half is non-ionized.
Right.
The general rule for onset is this. Drugs with a lower pKa, meaning their pKa is closer to the body's normal pH of 7.4, will have a more rapid onset of action.
Why lower pKi means faster onset.
Because at body pH, 7.4, a greater proportion of the drug with a lower pKi exists in its fat-loving, non-ionized form. That form penetrates the nerve membrane faster.
More membrane crossing form available, faster entry, faster onset.
Precisely. Lidocaine, pKa around 7.7, is a good example known for its rapid onset.
Okay, and higher pKi means?
Drugs with a higher pK, like bupivacaine, pK 8.1, or tetracaine, are more ionized, more in their water-loving form at body pH. This results in slower onset because less of the drug is available in the form that can easily cross the nerve membrane.
Slower to get in, makes sense. Any exceptions?
Yeah, an interesting one is chloroprocaine. It has a high pKa, but it actually has a rapid onset.
How come?
It's likely because it's typically used in very high concentrations clinically. So even though a smaller fraction is non-ionized, there are just so many drug molecules available that enough get across quickly to start the block. Quantity overcomes the pKa disadvantage in a way.
Sheer numbers, got it.
Okay, now let's consider vasomotor action and absorption. This is about how the drug affects local blood vessels and how that influences its journey.
Right, you mentioned this affects duration.
It does, significantly. Most local anesthetics cause relaxation of vascular smooth muscle. This leads to vasodilation. They open up blood vessels near the injection site.
Wider blood vessels, what does that do?
Well, vasodilation increases local blood flow. More blood flowing through the area means the drug gets absorbed into the bloodstream faster.
So it gets washed away quicker.
Exactly. Which, in turn, limits the duration of action at the target nerve site because the drug doesn't stay concentrated there as long.
And more absorption means?
It increases the probability of systemic toxic effects because more of the drug enters the general circulation. So vasodilation is often an undesirable effect for local anesthesia.
Okay. Are there exceptions? You mentioned cocaine earlier.
Right. Cocaine is a potent vasoconstrictor because it blocks norepinephrine reuptake. That's unique among local anesthetics.
Constricts blood vessels.
Yes. Also, ropivacaine and lidocaine can actually have mild vasoconstrictive properties when injected, depending on the dose and site, but generally, most cause vasodilation.
Okay, so if vasodilation is usually bad, what do clinicians do?
They often add a vasoconstrictor to the local anesthetic solution. The most common one by far is epinephrine.
Epinephrine, like adrenaline.
Exactly. Adding a small amount of epinephrine achieves several key benefits. First, it reduces the rate of vascular absorption. It constricts those local blood vessels.
So it slows down the washout.
Precisely. This allows more of the local anesthetic to remain concentrated right there at the injection site.
Keeping the drug where you want it.
Right. This increased local availability then enhances the drug's uptake into the neurons, resulting in a longer and more profound block. More drug available for longer means a better block.
Makes sense. Any other benefits?
Yes, crucially, this slower absorption also significantly attenuates the peak blood level of the local anesthetic. Less drug gets into the bloodstream at any one time,
Which
reduces the risk of systemic toxicity. It's a major safety benefit. Think of it like putting a tiny tourniquet around the injection site, keeps the drug local, and limits systemic exposure.
Longer block, stronger block, safer block. Sounds like a win-win-win.
It often is, yes. However, the effect of epinephrine on duration isn't uniform across all local anesthetics or all body sites.
Oh, how so?
It definitely prolongs the duration for agents like lidocaine or methemoglobinemia when used for infiltration or most peripheral nerve blocks.
Okay.
But for highly fat-soluble drugs like bupivacaine, especially when used for epidural anesthesia, epinephrine often has no significant effect on the duration.
Why not in epidurals with bupivacaine?
It's thought to be because the fat in the epidural space significantly absorbs these highly lipid-soluble drugs anyway. It creates its own slow-release depot effect that kind of overrides epinephrine's vasoconstriction effect on duration. The drug is already sticking around because of the fat.
The fat acts like a sponge. Interesting. Does epinephrine always reduce the peak blood levels for safety?
It reduces peak levels for drugs like lidocaine and methemoglobinemia, but for prelocaine, which is rapidly redistributed anyway, or bupivacaine due to that lipid uptake, epinephrine might not significantly lower the peak plasma levels, even though it might still prolong the block duration in some settings. Generally, yes, in the small doses used. But there has been some controversy regarding potential neurotoxicity, although that's debated. It's also used as a safety measure itself. Injecting a test dose with epinephrine can help detect if the needle is accidentally in a blood vessel, because you'd see a quick heart rate increase.
Yeah.
Especially important if not using ultrasound guidance.
Okay, a multi-purpose additive. Are there other factors affecting onset and duration?
Yes, several miscellaneous factors can play a role. One interesting concept is ion trapping.
Ion trapping. Sounds dramatic.
It can be. Remember how local anesthetics exist in ionized, water-soluble, and non-ionized, fat-soluble forms, and the balance depends on pH?
Yeah.
Ion trapping occurs when the drug's ionized form gets trapped on one side of a membrane because of a pH difference between the two sides. The ionized form can't easily cross back.
Okay, trapped due to pH. What are the consequences?
Clinically, it can be significant. For example, if a patient has acidosis, their blood pH is too low, maybe from severe illness or even a local anesthetic overdose itself. The acidic environment in the brain can increase the ionized form of the local anesthetic there. This makes it harder for the drug to cross the blood-brain barrier out of the brain, potentially prolonging or enhancing CNS toxicity.
So acidosis traps the drug in the brain. Not good.
Not good at all. Similarly, in infected or inflamed tissues, which tend to be more acidic than normal tissue,
Right.
local anesthetics become less effective. The acidic environment increases the ionized, water-soluble form outside the nerve, diminishing the amount of fat-soluble drug available to penetrate the nerve membrane.
So infection makes numbing harder because the drug gets ionized outside and can't get in easily.
Exactly. It's like trying to use a key that doesn't quite fit the lock anymore because its shape changed.
Makes sense. What about adding things to the local anesthetic besides epinephrine?
Well, historically, carbonated local anesthetics were explored. The theory was that adding CO2 would make the solution slightly acidic, but the CO2 would diffuse rapidly into the nerve cell, lowering the intracellular pH.
Lowering pH inside. Wouldn't that trap the ionized form inside?
That was the idea. Trap the active ionized form closer to the sodium channel receptor after the non-ionized form got in. It showed promise in lab studies, speeding onset.
Did it work clinically?
The clinical reality was controversial. Studies often fail to show consistent benefits, possibly because the body buffers CO2 so rapidly. This practice is largely abandoned now.
Okay, so carbonation didn't pan out. What about sodium bicarbonate? Adding alkali?
Yes, adding sodium bicarbonate or alkalinization is actually widely used, especially in epidural anesthesia.
Why add bicarbonate?
The goal is to speed the onset of sensory and motor block. The mechanism is the opposite of the infected tissue problem. Increasing the solution's pH increases the proportion of the non-ionized fat-soluble state of the drug.
More fat-loving form available right away.
Exactly, which diffuses more readily across cell membranes, speeding onset. Some studies show it works well, though effects can be variable, especially if epinephrine is also present.
Any downsides to adding bicarb?
The major limitation is precipitation. The local anesthetic can literally fall out of solution, forming visible solids, especially if you add too much bicarbonate, or if the solution already contains epinephrine, which needs acidity for stability.
Gotta be careful mixing. Does it do anything else?
An additional potential benefit is that alkalized solutions may result in less pain or stinging upon injection. The exact reason isn't perfectly clear, maybe less irritation from the non-ionized form, or just a faster block starting.
Less sting is always good. What about mixing different types of local anesthetics?
Yeah, clinicians sometimes try mixing local anesthetics. For example, combining a fast onset, shorter duration drug like lidocaine with a slow onset, long duration drug like bupivacaine.
Trying to get the best of both worlds. Fast start, long finish.
That's the idea. Get rapid onset and prolonged duration.
Does it work?
Clinical findings are mixed. Onset might not always be faster than the fast agent alone. Duration is often longer than the short-acting agent, but shorter than the long-acting agent used alone. Kind of an intermediate effect.
Okay. Any risks?
Well, there's a potential for drug calculation errors when mixing. And importantly, the toxicity is generally considered additive. You don't reduce the overall risk of toxicity by mixing, you combine the risks.
So 1 + 1 = 2 for toxicity.
Pretty much. And with modern practice, especially the increased use of ultrasound-guided techniques,
Right.
clinicians can often use lower doses and place the drug more precisely. This potentially diminishes the need for these combinations anyway. Better targeting means less need for fancy mixes.
Makes sense. Okay, so once the drug gets absorbed, where does it go? Distribution and metabolism.
Right. Once local anesthetics are absorbed into the systemic circulation, they undergo rapid distribution throughout the body.
Where first?
The initial phase sees the drug quickly moving into highly perfused tissues organs with lots of blood flow. Think brain, heart, lungs, kidneys, liver.
The vital organs.
Exactly. This rapid distribution to vital sensitive organs is precisely why systemic toxicity, ALAST, is such a concern. The drugs can quickly reach high concentrations in these critical areas if absorbed too fast.
Okay. What happens after that initial rush?
After that initial rapid drop in plasma concentration as it fills those organs, there's a slower disappearance phase. This reflects redistribution into less perfused tissues like muscle.
Muscle takes up a lot.
Muscle actually receives the greatest amount of drug over time because it's such a large tissue mass, even though it's less perfused initially. And then there's ongoing metabolism and excretion clearing the drug.
How's it metabolized? Broken down.
The metabolism fundamentally differs based on whether they are esters or amides. Remember the I rule?
1I esters, 2I anides.
Yeah. Okay. Ester local anesthetics are metabolized very quickly, primarily by an enzyme in the blood called plasma cholinesterase. Hydrolysis happens right there in the plasma.
Fast breakdown in the blood.
Incredibly rapid. Procaine and chloroprocaine have plasma half-lives of less than a minute. This significantly reduces their potential for systemic toxicity because they just don't hang around long in the blood.
Wow, less than a minute. What about amides?
Amide local anesthetics are different. They are metabolized primarily in the liver by a specific group of enzymes called cytochrome P450 enzymes.
Liver metabolism for amides. Is that slower?
Generally, much slower than ester hydrolysis in the blood, yes. The rate at which amide local anesthetics are eliminated depends heavily on healthy liver function, both adequate hepatic blood flow, getting the drug to the liver, and the activity of those liver enzymes.
So liver problems would be an issue.
Absolutely. Conditions that impair liver function, like severe liver disease or conditions that reduce blood flow to the liver, can significantly prolong the time amide drugs stay in the body. Lidocaine's half-life, for example, can triple in severe hepatic disease.
So doses might need adjusting.
For continuous infusions or repeated blocks in patients with significant liver dysfunction, yes, doses are often reduced, maybe by 10–50%. For a single injection nerve block, usually no adjustment is needed.
Okay, and excretion, getting rid of it.
Only a tiny fraction, maybe 1 to 5%, of the injected local anesthetic is excreted unchanged by the kidneys. The vast majority is broken down into inactive, water-soluble metabolites first.
And those metabolites?
Those inactive metabolites are then primarily excreted in the urine. So while kidney dysfunction has less impact than liver failure for amides, severe renal disease could potentially lead to accumulation of metabolites, though their toxicity is usually low. Maybe a small dose reduction in severe cases.
Okay, mostly liver for amides, blood for esters. What about pregnancy? You mentioned things change then.
Yes, pregnancy introduces some special considerations. Both clinical observations and formal studies consistently show an increased spread and depth of spinal and epidural anesthesia in pregnant women.
Increased effect.
Yeah.
Meaning they need less drug.
Exactly. A lower dose of local anesthetic is often needed to achieve the same level of block compared to non-pregnant individuals.
Why is that?
It's thought to be multifactorial. There are mechanical factors. The enlarged uterus can compress veins in the back, causing epidural veins to dilate. This physically narrows the epidural and subarachnoid spaces, effectively concentrating the drug injected there.
Less space, higher concentration. Makes sense. Anything else?
Yes. Hormonal changes also appear to play a significant role. Increased sensitivity is seen even in early pregnancy, before the uterus is that big. There seems to be a relationship between progesterone levels in the cerebrospinal fluid and increased drug spread and nerve sensitivity.
Hormones make nerves more sensitive.
It appears so. Studies on isolated nerves from pregnant animals confirm this. They show greater sensitivity to local anesthetic blockade. So it's likely a combination of mechanical and hormonal factors leading to increased effect in pregnancy.
Fascinating. Now, you mentioned a really surprising new area, local anesthetics and tumor recurrence.
Yes, this is a very recent and truly intriguing area of research. Several studies, both looking back at patient records and looking forward, have suggested that using regional or local anesthesia during cancer surgery may actually improve patient survival and the disease-free interval afterwards.
Wow. Regional anesthesia might help fight cancer recurrence. How?
The potential mechanisms are thought to involve both direct and indirect effects of the local anesthetics.
Okay, direct effects.
Direct effects could include interference with cellular pathways that promote tumor growth. Some studies even suggest local anesthetics might have direct toxic effects on cancer cells themselves, especially when used for infiltration around the surgical site.
Killing cancer cells directly.
Potentially, yes, at high local concentrations. But the indirect effects might be even more significant.
Indirect effects.
These involve reducing the body's perioperative stress response and preserving the immune response. We know that major surgery triggers a significant stress response, often involving the sympathetic nervous system.
Fight or flight.
Right. And unfortunately, this stress response can suppress the immune system at a critical time, potentially promoting the growth of any microscopic cancer cells left behind after surgery.
So surgery stress can help cancer grow back.
That's the concern. The hypothesis here is that by blocking the pain signals traveling from the surgical site to the brain using regional anesthesia, local anesthetics significantly blunt this detrimental sympathetic stress response.
Less stress signal, less immune suppression.
Exactly. Potentially allowing the body's own immune system to remain more active in fighting off any residual disease. It's a fascinating concept, using pain control to indirectly boost anti-cancer defenses. Still early days in research, but very exciting.
This is truly incredible. It's where you realize these aren't just simple numbing agents. The science is incredibly deep.
It really is.
And it has profound implications, even in areas like cancer treatment. But, with great power comes great responsibility. We need to talk about the potential downsides, too. Specifically, that rare but serious complication. Local anesthetic, systemic toxicity, or LAST.
That's right. While local anesthetics are remarkably safe when used properly by trained professionals, it's absolutely critical to be aware of local anesthetic systemic toxicity. LAST.
LAST. Okay. How does it happen?
It's a serious, though thankfully rare, consequence of regional anesthesia. It occurs when too much local anesthetic gets into the bloodstream too quickly.
Too much, too fast.
Exactly. The most common cause is an inadvertent injection directly into a blood vessel, like accidentally hitting a vein or artery during the
Okay, accidental IV injection. Any other way?
Yes. It can also occur from the absorption of large amounts of drug from certain nerve blocks that require very high volumes, or are done in areas with lots of blood vessels, where absorption is naturally faster. Or, less commonly, from continuous infusions where the drug and its metabolites gradually accumulate over days.
So injection error, high dose absorption, or slow buildup.
Those are the main scenarios. The fundamental mechanism of LAST is that the local anesthetic, once it reaches high levels in the blood, starts to depress those very same voltage-gated sodium, potassium, and calcium channels we talked about earlier.
The ones in the nerves.
Yes, but now it's affecting them systemically, particularly in the excitable tissues of the central nervous system, CNS, the brain, and the cardiac system, the heart.
Brain and heart effects. That sounds bad.
It is. This widespread channel blockade is what causes the diverse and potentially dangerous symptoms of LAST.
Okay, let's break that down. What happens in the CNS, the brain?
Normal brain function relies on a delicate balance between excitatory neurons, which stimulate activity, and inhibitory neurons, which calm activity.
Excitation versus inhibition.
As AS progresses and the local anesthetic blood levels rise, it seems to preferentially block the inhibitory neurons first.
Blocks the calm down signals.
Effectively, yes. This leads to a state of unopposed excitation in the brain, which is thought to be the primary mechanism behind the seizures often seen in patients experiencing LAST.
This inhibition causes seizures. Makes sense. What if levels get even higher?
At very high drug levels, even the more resistant excitatory pathways eventually get inhibited too. This leads to more severe CNS depression like unconsciousness and coma.
Okay. Is there a typical progression of symptoms?
The classical progression, though not always seen, often starts with subtle signs. Lightheadedness, maybe ringing in the ears, tinnitus, numbness or tingling around the mouth, blurred vision, sometimes a metallic taste.
Early warning signs.
Hopefully. These can then progress fairly quickly to muscle twitching, then unconsciousness, then generalized convulsions or seizures, and eventually, with extremely high levels, respiratory arrest.
Okay, that's the brain. What about the cardiac effects?
The heart's function, its electrical activity and contraction, depends on similar ion channels. So, blockade of cardiac sodium, potassium, and calcium channels by toxic levels of local anesthetics profoundly affects the heart. It disrupts the initiation and propagation of the electrical impulse that makes the heart beat, and also affects the heart cells' ability to repolarize or reset themselves.
So it messes up the heartbeat.
Yes. Clinically, this leads to decreased contractility, The heart muscle pumps less effectively, becomes weaker, and various arrhythmias or abnormal heart rhythms. Bradycardia, a dangerously slow heart rate, is a common and very concerning presentation.
Slow heart rate. Any other signs?
Sometimes initially you might paradoxically see a brief period of hypertension and fast heart rhythms, but this usually quickly progresses to depressed cardiac conduction, reduced cardiac output, less blood pumped, severe bradycardia, and profound hypertension, low blood pressure, potentially leading to cardiac arrest.
Very serious. Does the type of local anesthetic matter for toxicity?
Yes, definitely. The type of local anesthetic plays a significant role, especially in the severity of cardiac toxicity.
How so?
Shorter-acting lidocaine, for example, is considerably less cardiotoxic than the longer-acting and more potent bupivacaine.
Bupivacaine is more dangerous for the heart.
Historically, yes. Bupivacaine has been implicated in the greatest number of reported deaths related to LAST. The difference seems linked to their properties. The more potent agents, like bupivacaine, are more lipid-soluble and protein-bound,
Right. More potent, longer duration.
which means they bind more tightly and for longer to those critical cardiac sodium channels, leading to a prolonged blockade and making resuscitation much more difficult. Recovery is delayed.
So they stick to the heart channels more.
That's a good way to think of it. Newer agents like ropivacaine and levobupivacaine, which is just the left-handed version of bupivacaine, were specifically developed to have less cardiotoxicity than bupivacaine.
Safer alternatives.
They are generally considered safer from a cardiac standpoint, yes, but it's vital to remember that caution is still paramount. Large doses or accidental intravascular injection of any local anesthetic can still cause LAST. No drug is completely without risk.
Good point. You said LAST is rarer now. Why the improvement?
Our understanding and practices have significantly evolved. We've seen a dramatic reduction in the incidence of larcine since the 1980s. While estimates vary, it's now considered a very rare event compared to before, maybe around 0.3 occurrences per 1,000 peripheral nerve blocks, for example.
That's a huge improvement. What changed?
It's attributed to the widespread adoption of enhanced safety measures by anesthesiologists and other clinicians performing blocks.
Like what specifically?
Key factors include the now widespread use of ultrasound-guided regional anesthesia.
Ultrasound helps avoid blood vessels.
Exactly. It allows for direct visualization of the needle, the target nerves, and surrounding structures, including blood vessels, in real time. It also lets you see the drug spreading so you can use lower volumes more effectively.
Okay, ultrasound is huge. What else?
Other crucial steps include routinely aspirating before injection, pulling back on the syringe to check for blood,
This is standard practice.
injecting the local anesthetic incrementally in small amounts, like 3 to 5 millidales at a time, with pauses in between, rather than one big, rapid injection.
Slow and steady.
Using vascular markers like that small test dose of epinephrine, especially for certain blocks, using lower overall local anesthetic doses whenever possible, and performing blocks with patients who are awake or only lightly sedated.
Why awake?
So they can report those early CNS symptoms like tingling lips or ringing ears immediately, giving an early warning before things potentially escalate, and maybe using drugs like midazolam for sedation, which might slightly increase the seizure threshold.
A whole bundle of safety measures making a difference.
Absolutely. It's a system approach.
How does LAS typically present now, given these changes? Is it always that classic seizure progression?
Not always. The clinical presentation can vary. Based on registry data, maybe around 43% of cases still follow that classic progression. CNS excitation signs first, agitation, tinnitus, numb lips, leading to seizures.
Okay, still common.
But it's crucial to know that about 24% of cases involve isolated cardiovascular symptoms alone. Maybe just sudden bradycardia or low blood pressure, often with a delayed onset, without any preceding CNS signs.
Just heart problems? No warning signs from the brain. That's tricky.
Very tricky. And roughly a third of cases present with a combination of both CNS and CV symptoms right from the start.
Okay. And the timing? Is it always immediate?
Highly variable. After a single injection, symptoms can start anywhere from 30 seconds up to an hour later. Although it's rapid, in many cases maybe 75% within 10 minutes, that delay is possible and important to remember. Vigilance is needed beyond the first few minutes.
Good to know. So prevention is key. Can you summarize the absolute must-dos for preventing LAS?
It's really a multifactorial approach, as no single step is foolproof. But the key suggested safety steps are:
Okay.
first, use the lowest effective dose. That means the lowest concentration and volume that will still get the job done. Question those old maximum dose rules based just on body weight, as absorption varies hugely by site.
Lowest effective dose. Got it.
Second, incremental injection. Inject slowly, 3 to 5 milliliters at a time, pausing 15-30 seconds between each allocort to watch the patient and monitor.
Incremental injection.
Well,
Check.
third, aspirate the syringe carefully before each injection, looking for blood. Recognize it's not perfect, you can get false negatives.
Aspirate. Check.
Fourth, consider using intravascular markers like that epinephrine test dose, maybe 10-15 micrograms in adults, for higher risk blocks, monitoring for changes in heart rate or blood pressure.
That's dose marker. Check.
Fifth, use ultrasound guidance whenever feasible. It's strongly supported for reducing last risk.
Ultrasound. Definitely.
And finally, maintain meaningful verbal contact with the patient if they're awake or lightly sedated, and always be aware of the additive nature of toxicity if multiple injections or different local anesthetics are used. Document doses clearly.
Okay, a whole checklist for safety. What happens if, despite all that, LAST is suspected? Diagnosis and treatment.
If LAST does occur, prompt recognition and immediate correct treatment are absolutely essential to minimize adverse outcomes and potentially save a life. Time is critical.
Okay, first steps.
Immediate interventions focus on the ABCs, really. Airway management is paramount. Secure the airway, make sure the patient is getting 100% oxygen, and ventilate if necessary.
Oxygen first. Why is that so crucial?
Preventing hypoxia, low oxygen, and acidosis, acid buildup, is critical. Acidosis, as we discussed with ion trapping, can dramatically worsen acid toxicity, especially in the brain and heart. Oxygen helps prevent both.
Okay, airway and oxygen. What about seizures?
Seizure suppression is the next priority. Benzodiazepines, drugs like midazolam or diazepam, are the drugs of choice.
Why benzodiazepines?
Because they're effective anticonvulsants but generally don't cause significant cardiac depression, which is vital when the heart might already be compromised by the local anesthetic. Small doses of propofol are an alternative if benzos aren't immediately available, but you have to be very cautious if there's any cardiovascular instability.
Okay, benzos for seizures. Then the heart.
Cardiovascular support is essential. This might involve fluids, potentially vasopressors, drugs to raise blood pressure, and managing arrhythmias according to advanced cardiac life support, ACLS protocols, but with some key modifications for LAST. The goal is maintaining blood flow, especially to the heart itself. Remember, LA toxicity isn't usually permanent cell damage if you can support the patient through it.
Okay, standard support but modified. What's the big modification?
The game changer, lipid emulsion therapy, LET. Using a 20% intravenous lipid emulsion.
Lipid emulsion, like 5e fats.
Exactly. It sounds strange, but it's now a standard part of LAST resuscitation recommended by major anesthesia societies worldwide. It has shown remarkable ability to reverse severe toxicity, especially the cardiac effects, and can even restore circulation after cardiac arrest due to LAST.
Wow. How does it work? Does it just soak up the drug?
That was the original lipid sink theory, that the fat emulsion just passively absorbed the fat-loving local anesthetic out of the plasma. But the understanding now is more complex. It likely involves multiple mechanisms. One is a shuttling effect. The lipid emulsion acts more like a dynamic carrier, actively scavenging the local anesthetic from sensitive organs like the heart and brain, and helping redistribute it to safer storage tissues like muscle and liver for detoxification.
A lipid shuttle, not just a sink.
Right. It also seems to have direct cardiotonic effects, meaning the lipids themselves help improve heart muscle contractility and blood flow. And there might be cardioprotective effects, activating pathways that protect heart cells from injury, similar to how the heart protects itself during ischemia.
Multiple benefits then. How's it given?
There are specific dosing protocols, usually involving an initial bolus based on weight, followed by a continuous infusion. For an average adult over 70 kilograms, it might be a 100 milliliter bolus over 2 to 3 minutes, then an infusion of 250 milliliters over 15-20 minutes. Repeat boluses might be needed.
Okay, specific dose. Are there drugs to avoid during ELST resuscitation with lipids?
Yes, this is critical. Current guidelines recommend avoiding vasopressin, calcium channel blockers, and beta blockers, as they may worsen outcomes. Also, if epinephrine is needed for blood pressure support, use reduced doses, like less than 1 microgram kg boluses, as large doses might interfere with the effectiveness of lipid emulsion and worsen arrhythmias.
Lower epi doses. What about arrhythmias?
Yes, if ventricular arrhythmias develop, amiodarone is preferred. Importantly, you should not use lidocaine or procainamide, which are also local anesthetics, to treat arrhythmias caused by LAST. That would just add fuel to the fire.
Makes sense. What if lipids don't work?
If the patient remains in cardiac arrest despite lipid emulsion and modified ACLS, the next step is to notify the nearest facility capable of providing cardiopulmonary bypass, heart-lung machine. This might be the only way to support circulation until the drug wears off in refractory cases.
Bypass is a last resort.
Wow.
This really underscores the seriousness.
It does. And it highlights why awareness and swift correct action are so critical. The early signs can be subtle, progression can be rapid, and knowing these treatment steps, especially having lipid emulsion readily available where blocks are performed, can be life-saving.
Every second counts. Incredible how much has evolved in understanding and treating this, especially with the lipid therapy. But you mentioned there's more to the story of side effects.
Right.
While last is the big, scary systemic complication, local anesthetics, like any powerful medication, can have other potential adverse effects, even if they're often rare.
Yeah.
Let's delve into some of those other important considerations.
Indeed. Beyond last, we need to be aware of a few other things. First, allergic reactions.
Allergies. I thought people were allergic to Novocaine all the time.
That's a common perception, but true. Verified allergic reactions to local anesthetics are actually remarkably rare. Less than 1% of all reported reactions are true IgE-mediated allergies.
Less than 1%. So what are people usually reacting to?
Most reported reactions are actually due to other causes. Anxiety or panic attacks from the procedure or needle, maybe the effects of the epinephrine added to the solution like palpitations or feeling jittery, vasovagal responses, fainting, or even mild toxic effects from rapid absorption, not a true allergy.
Okay, so usually not a real allergy, but they can happen.
They can, though, very rarely. Esters, remember, the ones with one I, like Procaine, which Novocaine is a brand name for, have a higher allergy potential.
Why esters more than amides?
Because esters are broken down in the body into paraminobenzoic acid, PABA. And PABA is a known allergenic compound that some people react to. Amides are not metabolized to PABA.
Ah, PABA from esters is the culprit. Anything else cause allergies?
Yes, sometimes reactions can be caused by preservatives that used to be common in multi-dose vials, like methylparaben or metabisulfites. Methylparaben, for instance, is structurally similar to PABA. Removing it from single-dose dental cartridges greatly reduced reported reactions. Sulfites, used as antioxidants for epinephrine, can also cause hypersensitivity, especially in people with asthma.
Okay. If someone is allergic to one local anesthetic, are they allergic to others?
Here's a key point. Cross-reactivity is high among esters. If you're truly allergic to one ester, like Procaine, you're likely allergic to other esters, like tetracaine.
Okay.
However, allergy to amides is extremely rare, and crucially, there is no cross-reactivity between esters and amides.
No cross-reactivity. So if you're allergic to an ester, an amide should be safe.
Generally, yes. That's why if a patient reports a history of allergy, clinicians will often safely use an amide local anesthetic, like lidocaine or bupivacaine, perhaps from a preservative-free source, just to be extra cautious. If there's high suspicion of a true allergy, formal testing by an allergist is the way to go.
Good to know. What's next after allergies?
Another important, though uncommon, adverse effect is methemoglobinemia, often shortened to METKB.
Methemoglobinemia. That's a mouthful. What is it?
It's a blood disorder where you get high concentrations of an altered form of hemoglobin called methemoglobin in the blood. Normally, iron in hemoglobin is in the ferrous Fe2+ state, allowing it to bind and release oxygen. In METHB, the iron gets oxidized to the ferric Fe3+ state.
Ferric iron. What does that do?
Ferric iron Fe3+ cannot bind oxygen effectively. So METHB reduces the oxygen carrying capacity of the blood. It also shifts the oxygen-hemoglobin dissociation curve to the left, meaning the remaining normal hemoglobin holds onto oxygen more tightly and doesn't release it to the tissues properly.
Less oxygen carried and less oxygen released. Double whammy. Leads to tissue hypoxia.
Exactly. Lack of oxygen in the tissues. Normal METHB levels are less than 1%. Symptoms start appearing as levels rise.
What are the signs?
Around 10–20% METHB, you might see cyanosis, a bluish discoloration of the skin, lips, and nail beds, even if oxygen levels seem okay. As levels climb 20–50%, patients can get anxiety, headache, rapid heart rate, shortness of breath, confusion. Above 50–70%, it can lead to coma, seizures, arrhythmias, severe acidosis, and even death.
Very dangerous. How do doctors spot it?
Clinical clues include that cyanosis unresponsive to supplemental oxygen. Sometimes the patient's blood looks abnormal, kind of chocolate colored.
Chocolate blood, wow.
And a mismatch between the pulse oximeter reading, CQ2, which might be low, like 85%, and the actual oxygen level in arterial blood gas, PaO2, which might be normal. This is called a saturation gap. Definitive diagnosis is by co-oximetry, a special blood test.
What causes METHB?
Medications are the most common cause in clinical practice. Certain antibiotics, nitrites, and relevant to our discussion, certain local anesthetics.
Which ones?
primarily benzocaine and prilocaine.
Benzocaine, the topical one.
Yes, benzocaine widely used in over-the-counter sprays, gels, and lozenges. The FDA has issued multiple safety warnings due to reports of serious med-aid cases and even deaths associated with its use, especially for infants and young children using teething gels. Importantly, it doesn't seem strictly dose-related with benzocaine and can happen rapidly.
So avoid benzocaine in young kids.
The FDA advises against using benzocaine teething products in children under 2. For prilocaine, the risk comes from one of its metabolites, which can oxidize hemoglobin. This is generally dose-related. High doses should be avoided, especially in infants, pregnant women, or those on other oxidizing drugs.
Is there a treatment for Meta-B?
Yes, the primary treatment is an intravenous medication called methylene blue. It acts as an electron carrier to help reduce the ferric ion, Fa3, back to the functional ferrous, Fe+ state. Prompt recognition and treatment are critical.
Okay, allergies and Meta-B. What about direct toxicity to tissues?
Yes, local tissue toxicity can occur, though it's also rare with standard practice. One severe manifestation is cauda equina syndrome, CES.
Cauda equina, that's the bundle of nerves at the end of the spinal cord, right?
Exactly. CES involves damage to those nerve roots, causing symptoms like bowel and bladder dysfunction, incontinence or retention, saddle anesthesia, numbness in the groin area, and bilateral lower extremity weakness or sensory loss.
What causes it in relation to anesthesia?
While CES can result from things like a large spinal hematoma or disc herniation compressing the nerves, it has also been associated, rarely, with spinal anesthesia. Risk factors seem to include accidentally injecting super high concentrations or doses of local anesthetic into the spinal fluid, or maldistribution where the drug pools and doesn't spread properly, leading to neurotoxic concentrations in one area. Pre-existing spinal stenosis might also increase risk.
So usually related to high dose or poor spread in spinal anesthesia.
Historically, yes. There were issues decades ago with older formulations of chloroprocaine used for spinal anesthesia, which had a low pH and a preservative, sodium metabisulfite, that were likely neurotoxic at the high doses used then. That formulation isn't used intraleptically anymore.
What about other drugs?
Lidocaine was associated with CES when it was used for continuous spinal anesthesia via catheters, a practice largely abandoned now in the U.S. due to this risk.
Okay. Is single-shot spinal lidocaine risky?
Single-dose spinal lidocaine isn't typically associated with prominent CES, but it has been linked more frequently than other agents to transient neurologic symptoms, TNS.
TNS, what's that?
TNS is characterized by pain in the back, buttocks, and lower extremities, often described as burning, aching, or cramping that starts after the spinal anesthetic wears off and can last for a few days.
Pain after the block wears off. That sounds unpleasant.
It can be quite uncomfortable, yes, but the crucial difference from CES is that TNS is transient. It resolves completely, usually within 5 days, without any permanent neurological problem.
Okay, temporary pain, not permanent damage. Why does lidocaine cause it more often?
The exact mechanism isn't fully understood. It seems more common with lidocaine used for spinal anesthesia than other agents like bupivacaine. Patient positioning during surgery might also play a role. Fortunately, with newer techniques and alternative drug choices, TNS has become less of a clinical issue. Treatment is mainly supportive with pain relievers like NSAIDs.
Okay, good to know the difference between CES and TNS. Now let's shift gears. What about the broad clinical uses of these drugs, beyond just standard nerve blocks?
Absolutely. They have a wide range of applications. Let's start with topical anesthesia.
Numbing the surface.
Right. Various formulations, creams, gels, patches, sprays are used for countless procedures. Numbing skin before 5E insertion or blood draws, especially in kids. Circumcision, dressing changes, dentistry, minor skin surgeries, laser procedures, even pre-treating the skin before performing multiple injection regional blocks to make the block itself more comfortable.
Lots of uses.
Yeah.
You mentioned cocaine earlier as unique.
Yes. Cocaine is the only naturally occurring local anesthetic still in some clinical use. Its unique property, as we said, is blocking norepinephrine reuptake, causing significant vasoconstriction.
So it numbs and stops bleeding.
Exactly. That's why its primary use is for topical anesthesia of the mucous membranes of the nose and throat, often during sinus or throat procedures. Its use is declining due to toxicity concerns and potential for abuse, and there are strict dose limits.
Okay. What about that EMLA cream?
Right, eutectic mixture of local anesthetics, EMLA. It's a specific mixture of lidocaine and prilocaine base in an oil and water emulsion.
Eutectic.
A eutectic mixture is one where combining two solids lowers their melting point so they become liquid at room temperature. This helps the active drug penetrate intact skin. EMLA cream or patches achieve good dermal analgesia, usually needing about an hour under an occlusive dressing to work well. Very common for numbing skin before needle procedures.
Okay. Any others for topical use?
There used to be a mixture called TAC, tetracaine, adrenaline, epinephrine, cocaine, used for numbing traumatic lacerations, especially in kids, to avoid infiltration with needles. It combined the anesthetic effects with vasoconstriction. But due to the cocaine content and toxicity risks, its use has largely been replaced by other topical agents or careful infiltration.
Okay. What about injecting right into the wound? Local wound infiltration.
Very common. Injecting local anesthetic directly into the surgical incision edges before closure provides immediate short-term post-operative pain relief.
Just a one-time shot.
Often, yes. But for longer-term analgesia, say over several days, clinicians can place indwelling catheters near the surgical site, maybe under the skin, between muscle layers, even sometimes near nerves or joints, and infuse dilute local anesthetic continuously.
Continuous numbing through a tiny tube. Is that safe? What about last?
Interestingly, significant last has not been reported with these dilute continuous wound infusions via catheters, likely due to the slow rate and often lower concentrations used. The main issues tend to be mechanical catheter blockage, breakage, migration, or potentially infection.
Any other risks with wound catheters?
One specific concern that has emerged is chondrotoxicity damage to joint cartilage, particularly with high concentrations or prolonged continuous intra-articular inside the joint infusions of bupivacaine, especially in the shoulder. So caution is needed with intra-articular use.
Okay, risk of cartilage damage in joints. What about making the effects last longer from a single shot?
That's where sustained release local anesthetics come in. This has been a major innovation.
Sustained release, like a time release capsule.
Exactly the concept. The main example currently is liposomal bupivacaine, brand name Exparel. This encapsulates bupivacaine within microscopic multi-layered lipid structures called depofoam.
Fatty bubbles holding the drug.
Right. This formulation provides continuous and extended post-surgical analgesia for up to 96 hours, that's 4 days, from a single injection administered into the operative site by the surgeon at the end of the procedure.
4 days of pain relief from one shot. That's amazing.
It can be very beneficial, yes. It's indicated for specific surgeries like hemorrhoidectomy, bunionectomy, total knee replacement, hernia repair, some plastic surgery procedures.
Any special considerations?
Absolutely. It's crucial to understand that liposomal bupivacaine is not bioequivalent to standard bupivacaine. You can't just swap doses. And the bupivacaine doses are additive. If a patient receives liposomal bupivacaine and a standard bupivacaine block, the total dose must be carefully considered to avoid last. There are specific maximum doses for Exparel depending on the site of injection.
Got to be careful with dosing. Is it always better than other methods?
It offers convenience and potentially prolonged relief. However, some recent large studies, particularly in total knee replacement, suggest that when patients are already receiving comprehensive modern pain management, including things like peripheral nerve blocks, adding liposomal bupivacaine infiltration might not provide significant additional clinical benefit in terms of opioid use or complications. It might be most advantageous where other advanced techniques aren't fully utilized.
So useful, but maybe not a magic bullet in all situations.
Correct. It's another tool in the toolbox.
Okay, one more technique you mentioned in the outline. Tumescent anesthesia, TLA. What's that?
Tumescent anesthesia involves the subcutaneous injection just under the skin of relatively large volumes of very dilute local anesthetic.
Large volumes. How large?
Can be liters, up to 4 liters or sometimes even more. The solution is typically very dilute lidocaine, like 0.05% or 0.1%, usually mixed with sodium bicarbonate and epinephrine in normal saline.
Liters of dilute lidocaine under the skin. What's it used for?
Its primary use is for liposuction. The large volume of fluid containing dilute anesthetic and epinephrine helps to numb the area, constrict blood vessels, reducing bleeding, and physically distend or tumesce the fatty tissue, making fat removal easier and safer. The term tumescent refers to that swollen, firm state of the tissue.
That sounds like a huge amount of lidocaine, even if it's dilute. Is it safe?
That's the remarkable thing. Despite the potentially very high total milligram dosages of lidocaine administered, sometimes up to 35-55 milligram are exceeding traditional maximums, the resulting serum lidocaine concentrations typically remain well below levels associated with mild toxicity.
How is that possible with such large doses?
It's due to the extremely slow, delayed systemic absorption from that large subcutaneous depot of very dilute solution. The vast volume, the dilution, the subcutaneous space, which isn't richly vascular, and the vasoconstriction from the added epinephrine all combine to keep the absorption rate very low and spread out over many hours.
Slow trickle into the bloodstream over a long time.
Exactly. Peak serum lidocaine levels after tumescent liposuction might not occur until 12–16 hours after the injection finishes. This slow absorption is the key to its safety profile when guidelines are strictly followed.
Fascinating technique. Lots of innovation happening.
Definitely. Which leads back to your earlier point. As these new formulations like liposomal bupivacaine and techniques like TLA emerge, how do clinicians balance embracing innovation with the absolute need for continued vigilance regarding safety? It's an ongoing process.
Absolutely. It's clear that local anesthetics are far, far more than simple numbing agents. They are a complex, dynamic class of drugs with a rich history and an evolving future. From that microscopic dance of ions across nerve membranes to their broad clinical applications and the intricate safety protocols, you can truly see how understanding this science at a deeper level, really mastering it, empowers better, safer patient care. #outro.
So what does this all mean for you, our listener? We've really peeled back the layers today, haven't we?
We certainly tried. We looked at how nerves transmit signals, how local anesthetics precisely interrupt that process, and that fascinating array of factors influencing their effectiveness, from their chemical structure right down to how your body handles them.
The whole journey.
We've also delved into critical safety aspects, from the rare but serious LAST and its treatment, to other potential effects like allergies and Med-B. And we explored the diverse and expanding clinical applications revolutionizing pain management. Hopefully, you now feel incredibly well-informed.
We hope so.
Almost like you could step into the shoes of an elite professional in this field. You've got the deep dive knowledge now.
Well, knowledge is most valuable when understood and applied. You definitely now possess a comprehensive understanding of a truly vital class of medications. Hopefully that allows you to appreciate the precision and care involved in modern anesthesia and pain management. A thorough understanding of local anesthetic pharmacology. Everything we've discussed today is just essential for appropriate administration and management, whether it's in pain services, outpatient procedures, or obstetrics. Selecting the right drug, the right dose, the right concentration for a specific regional technique is absolutely critical for success and safety.
Right.
And the continued research, the new insights into AS prevention and treatment, especially innovations like lipid resuscitation, are genuinely making these already safe procedures even safer than ever before.
That's great progress. So as we wrap up, here's a final provocative thought to leave you with.
Okay.
As we continue to push the boundaries of pain management with new drugs like liposomal formulations and maybe others on the horizon, consider this. How might our ever-deepening understanding of these incredible microscopic interactions between drugs and nerves eventually lead to entirely new ways of managing pain? Could we potentially even replace the need for traditional surgery in some contexts down the line? What other deep dives await us in the future of medical innovation?
Intriguing questions indeed. The future is certainly exciting.
Thank you for joining us on this deep dive into the fascinating world of local anesthetics. We hope you've enjoyed the journey as much as we have. Until next time, keep digging deeper.